No way. You at 3 years old? I want to be the little
No, go back. Not from the current slide, from the beginning. There we go. Okay. Take this off. Look at, I even remembered to record already. Okay. Is anybody on Blue Button that can watch the chat? Okay. And then tell me how you can see the screen, if you can see it okay.
Let her go. Let her learn her way.
I used to try lotion on me, now I don't, and I swear, as soon as I stop trying on me, like 5 people ask me every day.
Is it loading?
Yeah, it's connecting.
Oh.
Good morning, Blue Button friends. Mark's going to watch the chat, so if you have a mic, then speak up if you need something, but otherwise, if you're in the chat, then he can kind of help answer or ask me questions. How's your camera? Are you there yet? Yeah? Oh, wow. It only took forever to get that, but the camera's okay. Okay, for this one, for musculoskeletal, I'm going to post some clickers. I don't know if you guys are far enough out that you know what clickers are, but we used to have like these little remote things. Did you guys have them in 05 with Jody?
Oh, yeah, they don't work.
Oh, didn't they? Well, we don't have them set up in these rooms, and so since I have them in their review questions, and I'm just going to go ahead and post those in the unit. And there's also a PowerPoint that is delegation and prioritization. It's a game that we played when we had lots of people to play a game, and they could be very close together, but they're good delegation and prioritization questions that are good NCLEX review, because you will have lots of those kinds of questions. So that isn't an assignment. It isn't something that's for the test. It's just something that's NCLEX help. Okay, and I will post, that one's there. I'm not sure if it's published yet. And then the post-op, so the little assignment that we'll have at the end, I'm going to leave you time so you can do it now, or you can, it's not due till Friday night. So, but I'll show you right after the lecture. So remind me to show you the assignment if I'm forgetting. So this is my last lecture for this semester. I always feel bad when I get to this point. I'm like, I will miss you guys, all, 7 of you that come. The rest of you guys, I guess I'll miss you too. I don't know hardly any of you except my clinical group. So come back when we don't have masks and introduce yourselves to us. All right. So my joke is actually somebody who's really funny this time. And let's see here. I had to go to my, there we go. My Chrome tabs here. I don't know how many of you guys have ever heard of Brian Regan. I think he's pretty dang hysterical. So let's see.
Like the one where you talk about your kids and things you never thought you'd have to say.
Yeah.
Stop dropping spaghetti on your kid.
I know. Yes. Okay. So can they see or hear this?
You know where it all went wrong was the day they started the spelling bee. Up until that day, I was an idiot, but nobody else knew, And the spelling bee day, popped up. All right, kids, up against a wall. It's time for public humiliation. Spell a word wrong, sit down in front of your friends. That's great little egos. Hey, look at me, I'm a moron. I wasn't even close. I was using numbers and stuff. That's why I admired that kid who spelled it wrong on purpose so he could sit down, you know? He knew he wasn't going to win, so why stand there for 3 hours? First round, cat, K-A-T, I'm out of here. As he passed you, I know there's 2 T's. I remember my teacher asked me, Brian, what's the I before E rule? I before E. Always. You an idiot, Brian? Well, apparently. So she explains that no, Brian, it's I before E, except after C, and when sounding like A, it's a neighboring way. And on weekends and holidays and all throughout May, and you'll always be wrong no matter what you say. It's a hard rule. That's a rough rule. Plurals are hard too. Brian, how do you make a word a plural? Put an S. Put an S at the end of it. When? Weekends and holidays. Oh, Brian, let me show you. So she asked this kid to do everything. Erwin, what is he plural for ox? Oxen. The farmer used his oxen. Brian. Now what's the plural for box? Boxen. I bought 2 boxes of donuts. No, Brian, no. Let's try another one. Erwin, what is the plural for goose? Geese. I saw a flock. Geese. Brian. Brian, what's the plural for moose? Moosin! I saw a flock of moosin! There are many of them, many much moosin! Out in the woods, in the woodins, in the woodsin! The meat's wanting food! Food is to eat, is it? The meat's wanting food in the woodin, is it? In the food in the woodin, is it? Brian, you're an imbecile. Imbecile! You speaking German, Brian? Jermaine Jackson! Jackson 5, Tito! What the hell are you talking about? I don't know, really. I think the worst day was the day the science project was due. Waking up that morning, that was fun, huh? Your head would pop off your pillow. Oh, no. That's due today. I had 9 months to work on it. I did nothing. I'm a cardboard box. A boxing. You show off, you're scared because you're doing everything good, and you find out all the other kids, their parents made theirs for them. I hated that, you know? They're backing on flatbed trucks. One kid with a volcano. He didn't have to zip up his own pants, but he built a volcano. I just swing down. I don't know what to do for my project, so I brought in a paper cup filled with dirt. Just she wanted to eat, just walk out as fast as long as I was holding something. What do you have there, Brian? A cup of dirt. Just put an F on there and let me go. Well, explain it. Well, it's a cup with dirt in it. I call it a cup of dirt. You should move on now. You should go ahead and move on. Head on down the line here.
Oh my gosh. He cracks me up. Alrighty. Boxing. About 2 boxing of donuts. Moosin', yeah. When you look at what she does with that and the differences, it is, our English language is so messed up. It is so hard. My daughter-in-law speaks English as a second language. And she speaks it very well, but every once in a while she gets tenses wrong or spelling in a text or something like that. But Um, she's like, this is so hard. Yes, the rules. Just 3 or 4 or 5 words, and then everything else is like, well, except for this. Well, except for this. Okay, let's see. Let's go back to why we're really here. Okay. Can they see it okay now again? Okay. All right. So our objectives for my portion are 8 through 12. Identify the clinical manifestations and therapeutic management of patients with osteomyelitis. Differentiate between the various types of fractures. Number 10, identify possible complications associated with fractures. Number 11, identify appropriate nursing care or teaching for the patient with a cast. And number 12, identify appropriate nursing care or teaching for patient interruption. So osteomyelitis, it's kind of interesting because 2 of my students in my clinical group both had patients that had osteomyelitis this last week. And I won't ask them to teach this part. Just put them on the spot. Infection of the bone, most often in the long bones, like the femur or the tibia. Though you won't see them as often in the shorter bones or like in the iliac crest or anything like that in the pelvic area, but most of the time in those long leg bones. It can be acute or chronic. Acute is usually related to an injury or a trauma or an infection of some sort that has traveled to that spot. We'll talk about that here in a second. And chronic can be from lack of circulation. So we have patients that have diabetes and they're going to lose a limb because they have had osteomyelitis maybe in their foot for a long time and they can't get it to heal. People who have decubitus ulcers that go clear to the bone can end up with osteomyelitis. And for some reason, it's twice as common in boys. Sorry, guys. All right, probably because they have more fractures, more trauma to their bones. All right, except in my house, out of my siblings, I hold the fracture record. All right, so right here is kind of where you would look at on a scan. And if that occurs in the epiphyseal plate, then it can cause growth problems. And especially in their legs, like if they have it for a long period of time and they're growing, like if they're like my 15-year-old who grows by the day, gets taller and taller, then they can end up with length discrepancies in their legs. So primarily it's bacterial, about 90% of the time. Sometimes it can be fungal, but usually that's someone who's immune compromised, otherwise from chemotherapy or something, and they're not able to fight that off well. An abscess forms in the bone, and the increased pressure causes secondary necrosis, and as the pressure increases, so does the necrosis of the bone. It can spread beneath the periosteum, and it causes thrombosis and increased necrosis. So you have the risk for clots, and that increased pressure will cause necrosis of the bone. They can have a sinus that spreads to the skin. So if you have, like if this is the bone, get in the way of the camera here, and you have an infection right here in the bone, then you can actually get kind of this tunnel up to the skin, this tunnel of infection, and it comes open as an open sore up on the skin. It can be a migrating illness. So it starts somewhere else and migrates to the bone. And this is the craziest thing. It can follow a respiratory illness. So somebody has an upper respiratory infection, particularly if it's something that is strep or staph, even if it's been treated with antibiotics, it still can migrate to the bone. Abscess teeth and pyelonephritis can also cause migratory problems to the bone. Most of the time, it's an injury from blunt trauma. So we would see it sometimes if someone was hit head on and it crushed the front of the vehicle into their legs. And then sometimes they would have problems with the long bones in their legs. The fracture that breaks the skin. So if they have a compound fracture, goes through the skin, now we have a higher risk of infection in the bone. External skeletal traction hardware, and we'll talk about traction at the very end. But they have, when they have pins and screws that are external, then they are at risk for osteomyelitis also. Any penetrating wounds, like a stab wound, can cause infection to go into the body that can then migrate to the bone. Any burns, because they ruin that layer of skin that keeps out all the microorganisms, so that we end up now having a lot of germs that can go through and into the bone. And it ruins the vasculature too, so they have decreased circulation to be able to heal the bone, and so that becomes a problem too. Postoperative, if they have surgical wounds and bone surgeries, so sometimes total hips, total knees, particularly total knees, can be set up for problems with osteomyelitis. Other causes, diabetes and hemodialysis. So with diabetes, they have decreased circulation a lot of the times in their periphery from damaged blood vessels. And so they are at risk for having infections because they don't have as good a circulation. But also with diabetes, and diabetes is actually the #1 cause for kidney failure. So they're usually on hemodialysis later in life if they've damaged their kidneys. And with hemodialysis, they're constantly accessing that catheter, that subclavian catheter, or a fistula that's in their arm. And so the risk of introducing microorganisms every single time they access that is pretty high. Peripheral vascular disease, so sometimes with your smokers that have Raynaud's syndrome in their hands and their feet, particularly their hands, where they have decreased circulation, can also be a cause. Decubitus ulcers, if they're stage 4, they go to the bone, and about 1/3 of those will end up with osteomyelitis. And just kind of an interesting little fact with that, if they have osteomyelitis, they can't put, or they won't put, a VAC dressing on that. So you know how a lot of decubitus ulcers, they'll put a VAC dressing on there. They won't with osteomyelitis. Best practice shows that actually can do more damage. If they have a weakened immune system from chemotherapy or splenectomy, and then any illegal drug use, because most of them don't use clean needles, so they just keep reintroducing infection. Clinical manifestations, there's a lot of pain and tenderness at the site. They can have some edema. And the decreased mobility, their decreased ability to bear weight. So they will feel like, it'll sometimes feel like that they've had an injury that maybe got better. So maybe they had some blunt trauma to their leg and it got better and they were walking again, but then all of a sudden now it's feeling like the injury's back, or that they can't walk well and they'll have a hard time bearing weight on that leg. They'll have a fever, and it's usually a pretty high fever, over that 100.4 kind of thing, where a lot of physicians want to be called, or 100.5. A lot of them will write an order that if a fever is over that, they want to be called. This can definitely be up in the 101, 102 range. It's can be quite high. Malaise, they feel very, very sick, and redness and warmth. So if you have it like in the tibia, then all the area around there is going to be very red and warm, can be kind of swollen up into their knee. And it has an abrupt onset, usually within about 7 to 10 days. So labs, they'll do blood cultures. So I was super dismayed on Friday, primaries. I can't remember, I think it was on the infant unit. Can't remember. Anyway, I won't sell out that student because they were like, "You're drawing blood cultures." And I was like, "Did they already start antibiotics?" And she goes, yep. And I was like, dang it! Because what's going to happen now? It's not going to be accurate, right? And so that is my biggest pet peeve. If they do antibiotics, they're like, oh, they have an infection, we can see it on the x-ray, we're going to hurry and slap them with antibiotics and then do all the rest of this later. and then they don't know what they're treating. They don't know what bacteria, what will work and what won't. So if you have someone that has an infection, any kind, and they're going to start antibiotics, always double check about blood cultures. Always double check first. An ESR and a CRP, anybody remember what those are for? Yes.
Like complement system and everything for information.
Very, very, very good. Yes, sometimes people don't remember the names of them. They just remember the acronym. So good job. But it is for inflammation. They're inflammatory markers, and they often travel together. But are they specific or are they non-specific? Non-specific. They just tell you there's a lot of inflammation, and then here you go, and then you got to figure out where, right? Then the CBC, often the white count can be over 25,000. So it's really, really high. The tests that they can do, x-rays, about 5 days post-onset, they'll be able to see that sore in the bone that I showed you on the x-ray. They can do a CT or an MRI even before that. So if they are having trouble and it's been a few days and now they're coming in, now it'll probably show up on an x-ray. But if it's pretty immediate and they can't see anything on the x-ray and they've got all this other symptomology, then they'll probably go ahead and do a CAT scan. And with the CAT scan, they can see a sinus a little bit better because you can see soft tissue involvement. And then with a bone biopsy, it's necessary to confirm the diagnosis and the pathogen. This isn't unfortunately often done, but if the blood cultures are done ahead of time before the antibiotics, then a lot of them will lean toward that and waiting a day or two, giving them a dose of a real general broad spectrum antibiotic and waiting for those blood cultures. This is done less, especially in kids, because it's just really painful. All right, so your therapeutic management, you want to get a complete history. This is what I asked two of my girls that had them. Did the patient have a respiratory illness prior to? And they said, they didn't get anything in report that they had. I'm going to look in the charting. And then when I followed up with one of them, they said, I haven't seen anything anywhere. So I asked them to ask the parents to see if there was any recent respiratory illness that these kids had had. And I don't recall that I remember to follow up with that. But that is a real big thing. So make sure you're getting a good history every time. I mean, I hope that that's something that plays through all of our lectures, is getting a really good history from your patients. Antibiotics, IV, minimum 6 weeks. That's best practice. And so a lot of these kids will be in the hospital for a little while, and then they'll place a PICC line. Once they're sure that it's osteomyelitis, and they'll place a PICC line, and then they'll be there for a little bit of time, but then they'll often go home, and they'll have home health. It'll come and follow up and do the antibiotics for that. They can follow up with oral as needed. So once they've had this 6 weeks, then they can follow up with oral if they're still having some issues. They're still having some pain, or if they're a boy, often I would see it with the boys, and they would give them some oral antibiotics just a little bit longer because they tend to have it kind of hang around a little longer. But just remember that they don't start here, okay? They start with the IV antibiotics. Sometimes they need to treat for months if it's chronic. So if they have a diabetic that has osteomyelitis maybe in a foot, sometimes they'll treat for months and months to see if they can get that better. And then they'll go home with a PICC. And then surgical incision and drainage, that's the I&D. They'll go in and they'll do an incision, and they'll kind of try to wash out that part of the bone or wash out the sinus that comes up to the skin. Sometimes they'll even have to put a drain in if they have a sinus. But they'll do that incision and drainage, and they'll try and clean things out. If it's someone who has chronic osteomyelitis, then sometimes they have to have an amputation. All right, for nutrition, they need increased calories. We want to make sure that we have enough energy to be able to fight this off. Infection control, so put them on contact precautions, particularly if they have an open sore. and then good hand washing. Medications that they'll give them, the antibiotics, analgesics. This is pretty painful. Anything that has to do with the bone is pretty painful, especially if they have tissue involvement too, and they have that sinus coming from the bone that has the infection in it, and an open sore can be really painful. And then antipyretics for their fever. You want to do education for them with about the treatment, about everything that we're doing, about their PIC care, what home health will do for them, and then any prevention coming up, like with diabetics, managing their blood sugars to keep from having more wounds, especially if they're having a chronic issue with them. So your prevention, reduce your high-risk activities, particularly IV drug use and increased risk. And I love this. This is in the literature. If you help them have reduce IV drug use, and they will be at a reduced risk. Absolutely. How much control do we have over that? Not a lot. Not a lot. So you do the education, you do the best that you can, and give them the risks. But ultimately, a lot of those people will choose the high and the risky behavior, even if they have osteomyelitis. I have a cousin who's a heroin addict, and he has been for, 15 years or so. And he is a mess, and he's a type 1 diabetic. So he's at risk of losing an arm, actually, has had osteomyelitis in his arm a couple of times, has open wounds, has had skin grafts, has had, but it's very hard. Usually they'll have to get a PIC just to get any blood work because he's burned out all of his veins. And he now has osteomyelitis in several toes and is probably going to lose a foot. But he's been told for all these years that these are risks and they're getting worse and worse and worse. And he chooses heroin over that. So do the best you can with education, but know that ultimately it's their choice, I guess. And you may see them again with more infections. So educate them on signs of increased infection. So like if their fever isn't going away or if the pain is getting worse. Risk for repeat infections, so the decubitus ulcers, so families that have little elderly people or someone who's an amputee that's in a wheelchair that needs to do pressure releases and move often, needs to be really educated really well at preventing those decubitus ulcers. And then diabetics with good blood sugar control, and then good hand washing when they're touching around the sore. All right, questions on osteomyelitis? Questions in the chat? I always forget about those guys. Sorry, you guys.
Nope.
Okay. All right, fractures. So infants can have fractured collarbones during birth, and other fractures are rare in infants because their bones are really pliable. Plus, they're pretty immobile, aren't they? So an explainable fracture would be very, very difficult if an infant had one. And so it is often something that can be contributed to abuse if they're too small to be very mobile. With the pliability, they will often have a green stick fracture, and I'll show you a picture of one. But basically, you have a stick that's dry and hard, like elderly people's bones, and it'll just crack. But if you have something that's kind of green, or you have a reed or something, then it can actually bend on one side and snap on the other. And so it's not broken completely through. Fractures in the first 2 years can be due to osteogenesis imperfecta, but more likely to physical abuse. So osteogenesis imperfecta is called soft bones, and they don't have enough collagen, and collagen is pretty key. It's a key protein in developing bones, and bones that are hard enough to not break very easily. They can break just sitting in a chair. I took care of a little boy one time that had, I don't remember right now, but it was upwards of like 30 fractures. And he would sit in his wheelchair and his pelvis would just snap. And it was so painful. And he was just really crippled and really kind of tiny, wasn't growing well. You know, they don't grow bone well, but then what they do have is very soft. those are kids that they really have to be really careful when they do skeletal surveys and make sure they may see fractures in various stages of healing. And so they need to be vigilant about doing some testing to make sure that this child isn't someone that is having some abuse issues. Any fractures that involve the epiphyseal plate or the growth plate can be pretty serious and can cause growth discrepancies. In your arms isn't necessarily that big of a deal if one's just a little longer than the other, but in legs it can cause a lot of problems. And so they'll end up sometimes needing a shoe that has a little thicker sole on one leg. So here's your epiphyseal plate right here in the epiphysis of the bone. And so you can see as it grows and forms more bone, if the fracture's right through there, how it can cause problems with that. So here's some types of fractures. You have a closed fracture or a simple fracture where it just breaks. If you take an open fracture or a compound fracture, then it breaks, but it comes through the skin. So you will hear it referred to as a compound fracture or an open fracture, either way. Then you have a displaced, can be open or closed. And this is often with a femur because those muscles are so strong. And so they break, that femur breaks, and then those muscles pull it together. And you have bone that like slides together against the other piece of bone. It may be open or it may be closed because sometimes as it pulls together, it pulls right through the tissue. And other times it just pulls it together. Okay, and then you have a comminuted fracture. It is like a shatter. So if somebody shattered their ankle or their wrist when they fell, and it's kind of a crush injury that causes that shatter. And then here's a spiral fracture. You can see how it comes down the bone like that. It's very, very hard to get a spiral fracture. And so if you have a young child, really question I don't know if the story's legit, and make sure that everything lines up. Some of the spiral fractures that I had taken care of were boys that were football players, that were linemen, and they'd have all that weight on their arms, and then somebody would hit a shoulder or grab them, and it would twist that other arm, and then they could end up with a spiral fracture. And then we had a little girl one time whose brother had her by the hands and was swinging her around in a circle and lost the grip on one hand and hit the ground and just twisted it and ended up with a spiral fracture. But she said the story, he said the story. Mom was like, I wasn't even there, so I didn't know the story. I heard her crying and I came running out. And she didn't have any other injuries. It was very kind of cut and dried. But I have seen a couple of spiral fractures that were with abuse, somebody who grabbed a child and kind of spun them as they threw them against the wall. And a couple others. Anyway, so she obviously had other injuries, lots of bruising, and then she even had swelling in her brain. And so, and then sometimes if they grab them to shake them, if they grab them by the arms and they're like shaking them like this, then sometimes they can spiral fracture an arm too. And then you have an open or compound fracture. Logan does not do well with pictures like this. And I had it up last night, just kind of flipping through my lecture. And he's like, why do you show stuff like that? Because it's pretty cool, actually. And then this is a green stick fracture where it just kind of bends on that one side, but then it fractures on the other. All right, clinical manifestations, if it's bending where it shouldn't be, it's probably fractured. If there's a lot of pain, probably fractured, especially if the story goes, jumped off, was doing parkour, jumped off the building, landed sideways on the fence, it broke and came down. There might be a fracture there. If the bone is sticking out, that's a good indication. Don't you love clinical manifestations that are super obvious? Yes. Like, oh yeah, these are good. I could do this. If there's swelling and bruising, and if there's an open fracture, there's the greatest chance of infection. What's that?
Oh, just my notes. It turned your smiley faces into question marks.
Oh, how funny. Oh. Okay, so I'm going to show you a quick little video. Let's see. Started at 9:30, right? Yeah, okay. I just want to make sure where we were at for a break. I'm going to show you a little video on ways that you can get fractures. Let's see here. You can show us, is that what you said? All right. I have to unshare and reshare Chrome tab. Let's see. I don't know if you guys have ever watched some of these ultimate fails. Holy smokes.
Oh, that's gonna be great. Whoa! Yes! Oh, the Amish.
Oh, I should have turned down the volume. Ah, sorry. I should have turned down the volume. You guys are going to listen to a lot of language. Sorry.
What the
Oh. I don't know why this one's in there.
Put on his Twitter. He's got the best Twitter account I've ever seen.
Parkour.
What? No!
Oh. I don't know why this one's in there, but it's super funny.
Take it off, take it off, take it off.
Take it off. Oh. I don't know why this is. Some of them are so dumb. And so it goes.
Oh.
I don't know what he was trying to do there. Lost his flip flop. Oh yeah. Oh. Okay. It's the guy that's on the camera. I could watch him for a long time. Oh. Oh, he's like, oh, okay. You can only guess how that one's gonna go. You know what the common denominator through all of these are? Yeah, I think there was one girl in there, the one that was sitting there that they all bounced on the thing on the beach and she went flying. Yeah.
I love talking. Oh my gosh, it's what redemption wrong.
Everyone's like the guy that has his head hanging out of the car. They smashed it in somebody's door like perfect space.
Who did that?
There's some kid, he was like hanging out of the car. His face, and then like somebody had a door opener or something.
Oh, no.
They have like
Oh,
dozens
wow.
of surgeries.
Oh, yeah. Okay, so moral of the story, don't do that stuff. All right, so diagnostic testing, x-ray, you can usually see that it's broken. And then if they're worried about soft tissue involvement, they can do a CAT scan too. The care of the fractures, open reduction is a surgical repair. So they're gonna open it up, and internal fixation is your plates and screws. So when they open it up, they usually put plates and screws in there to kind of hold it all together. And so if you ever see the term ORIF, it's an open reduction internal fixation. Exterior plates and screws are usually removed after they've healed. And the internal screws can be in there for a lifetime. Although I have seen some that have started to work their way out of the bone a little bit and are pushing on the skin, and they'll go in and remove that.
I have a patient who has inside fixation,
Uh-huh.
and one of the screws started coming out, and he got a screwdriver, pulled it the rest of the way out, and called the surgeon, and he was like, it came out, so.
What?
Like, all right, well, get a new one in there, I guess.
Oh my
Get
God.
it replaced. He was like, I thought if it came out, it would just be able to stay out.
Oh, wow. Oh my gosh. So she was saying that she had a patient, it was a newer fracture?
No, it was like, he was like 6 months post-op.
Oh, okay. 6 months post-op, had a screw that started coming out, so he just took a screwdriver and pulled it out.
Jenny said that
And then called the surgeon.
it looks like what her son got last week.
Who said that?
Jenny.
Oh, did she? Oh,
And
shoot.
Brooke said that's what happened to a staple in her knee.
Oh, yeah. I had heard that Jenny's kiddo had a
Yeah,
fracture.
you're rough.
Yeah. Yeah. All right. And then a closed reduction is where they just manipulate it or set it. And so sometimes when they come into the ED with a like an arm fracture, they have this little apparatus that can hang from the ceiling. It's like finger traps, kind of like the Chinese finger traps. You just stick their fingers in them, and then it just kind of hangs from the light over the bed. And we would give them propofol so that they're just out, and their arm is just very pliable. They would pull it down and set it, and then put them in a splint, and then give them an appointment for the orthopedist. And then we'd just wake them up. But sometimes traction, yep. So we'll talk about that at the end. But that's a closed reduction where they just kind of manipulate it and set it. And they have a portable X-ray machine called a C-arm, and it can kind of come around, and you can just set their arm kind of right up next to it. Everybody who's in the room just wears these lead vests throughout the whole procedure so that they can keep X-raying that arm and making sure that it's set the way that it should be. So here's a picture of some screws on bones that were broken and some pins in a hip. It doesn't look super fun, does it? All right, so with nursing care of fractures, you want to immobilize them. Immobilizing them very quickly. Immobilizing will help decrease pain because it also decreases some of the muscle spasms if you get that immobilized. Okay. You want to splint it or cast it. They don't cast it in the old plaster casts, which is nice because those suckers were super heavy. And if they got wet, then they got soggy and soft, and they would have to replace them. Now they have the fiberglass ones, which are super nice and super quick. They will often splint it and then send them to an orthopedist. They will look and see, they'll do an x-ray and make sure that it's lined up, looking okay. And sometimes they'll re-splint, or they'll have them come back in 2 weeks and have them do another x-ray just to make sure that it's starting to heal right where it should be. And by then, some of the swelling has gone down, and any of you have ever had a cast, it starts to get where you can move around in the cast. And so then sometimes then they will replace it. They'll cut it off and put a new one on. They used to wait 6 weeks and then pull them out of the cast and re-x-ray it and find out, oh, wow, it didn't heal like it was supposed to. And then have to re-break it. And then put it back in a cast to heal. So now they've gotten smart enough to realize we probably should look at it a few times before then. It begins to heal pretty immediately after the fracture, and kids will heal faster because they have a higher metabolism. Ice elevation, those are wonderful, wonderful things. When they have some swelling and they have a fracture, analgesics, they're very painful. Although I have had a friend that's had a couple, and she's like, yeah, it's broken. Let's go to the ED. And I'm like, no, when I broke both my arms and my leg, no, it was very painful. Antibiotics, PRN. So they won't give them just to everybody, but usually with the open fractures, okay, that come through the skin. And then doing really good education for families on what we're doing, why we're doing it, how they can help by keeping it iced and elevated. CMS checks. So I cover this. You guys online don't cheat. I can't cover it all the way. What are your 5 components of your CMS check? Yeah, edema and color. Yep. Yes. And so, there we go. I'll give it back to you. Make sure that you're checking all 5 pieces of circulation, not just a cap refill or not just a pulse. Check all 5 pieces, but remember that all 5 are only circulation. Because then you have motion. Can they wiggle their fingers? Can they hyperextend? So flex, let's see. Flexion, extension, hyperextension. I gotta figure it out here. And if they can hyperextend a little bit, then that's a good sign. But if they can't, if they can barely wiggle their fingers, then you might have a lot of pressure in there that you need to watch and make sure that it's not getting worse. And then with their sensory or sensation, you need to do, I think, at least 2 separate points. But if you do the outside of the thumb and the web and the outside of the pinky, you will do all 3 nerves that innervate the hand. Okay, so then you have a really good assessment there. I think I covered all the Doppler. Doppler is super important. If a Doppler is just a little, looks like a pen or a pencil, it's just tiny, put a little bit of ultrasound gel on a pulse point and see if you can find a pulse. If you cannot, so first try and find your pulse. If you can't, get a Doppler before you call your physician. Because if you call your physician and say, I don't have, can't find a pulse, first thing they're going to say is, get a Doppler. Yeah. So try and get a Doppler before you call them. Now, if you have a hand injury and the cast goes clear down to the fingers here, you're not going to be able to get a pulse. So you need to rely on those other pieces of circulation information, right? Mm-hmm. And then your sensory and your motion.
I use Dopplers for mastectomies to tell if it's actually going to push the tissue.
Yeah, Dopplers for mastectomies. Yep, they do, and to make sure, and you do them often to make sure there's still circulation. Yeah, right after surgery, it's like Q hour. All right, so you've got 5 P's. Pain, pulse, paresthesia, paralysis, and pallor. It's the same as a CMS check, but it adds pain in there. So sensation, circulation, sensation, motion, circulation. You see how they all fit into a category of your CMS check. So your pain, is it new? Is it unrelieved? Is it worse with movement? So if they're doing okay and they've been, you've been able to control their pain post-operatively, and maybe they have a splint now and they had an open reduction internal fixation and now it's just got a bit of a splint on there, and they start to have more pain and you can't manage it, and that's an indication that maybe we have too much pressure in the tissue and they might have compartment syndrome. With the pulse, the Doppler, paresthesia is numbness and tingling, so that's a numbness and tingling in there, that sensation like it's been asleep. And then paralysis, if they're unable to flex their fingers or their toes. So all of these are obviously most distal to the injury, right? And then pallor can be very, very pale. So it can be cool, but it can also be pale. Sometimes you might have sluggish cap refill, but you do have a pulse and you do have those other pieces of your circulation intact. So then you just watch it closely. But the more pieces that you lose or that of that circulation assessment, or more of these that are in categories that you don't want them to be in, like maybe they have a lot of numbness and tingling and they can't move very well. It seems like their color and temp are okay and their pain's okay, but you're concerned about some of these. That's a really good patient to watch closely and make sure that that's not getting worse. So compartment syndrome is the accumulation of fluid in the fascia, and that kind of encompasses the muscle and makes them stay in muscle bundles. And so when there's swelling in the tissue, it starts to exert this pressure and it has nowhere to go, because that is pretty unforgiving in those muscle bundles like that. And they need to do a fasciotomy. I think I have, that's the fascia. That's fasciotomy. And so they will cut straight through there because it's much easier to heal a surgical wound than it is one that actually just blows open. And I promise you it happens. I had a patient one night that she was at a class reunion and she had been on blood thinners. I don't remember why, but her INR was 7. Therapeutic, they like it 2, 3, so it was 7. She hadn't been going in for her tests for her Coumadin levels or her warfarin levels, and she bumped into a chair, like just stepped back and kind of bumped into a chair with her calf. Didn't think anything of it until it just immediately started to hurt more and more and more, and it was so painful she couldn't hardly walk, and it was getting really, really swollen. So they went to the emergency room. And in the course of them doing the blood work, it blew open. Like it literally exploded in the ED. The estimated blood loss was about 300 mils. And now they had this massive wound. We put a pressure dressing on, had to tend that pressure dressing that was just bleeding through until they could get her to surgery. But I ended up having to give her a couple of bags of plasma, unit of red blood cells, lots of fluid. Vitals were in the toilet. Like she kind of kept saying, "Am I gonna die?" as she was like fading. And I'm like, "Not on my shift. Not on my shift. We will do this. We're gonna get through this." But anyway, finally had to go to surgery and had to kind of hook all this back together, right? And sew all this tissue together, or try and put a wound back on there where you've got different pieces of tissue all different lengths and sizes, as opposed to just that nice surgical wound. So if they have to, I've seen one from hip to ankle, all the way down, had to do a fasciotomy because this little gal got drunk at a party and passed out laying on the cement for a long period of time, just on the side. Nobody thought anything of it. They figured she had alcohol poisoning and she was barely breathing. But they found her the next morning. Some of the friends couldn't really wake her up. So they got her up, but that lack of blood flow from laying on the cement caused necrosis in the tissue, a lot of swelling, and they ended up having to do a fasciotomy all the way down. And she was in the hospital for a long time with a lot of complications. The only thing that was good was that they were able to put a wound back in there and start to pull that together because they were able to get that fasciotomy before she had further problems. Crush syndrome. So you have an earthquake or something and it pins somebody and you've got this big slab of cement or a desk or a piece of ceiling or whatever is pushing on this person. When they have a lack of circulation to a certain area, particularly their trunk or their upper legs, they start to have, the cells start to need anaerobic metabolism because they're not getting enough oxygen because they're being completely smushed basically, and you don't have enough oxygen to the tissue and to the cells. They kick into anaerobic metabolism, and that starts to build up lactic acid. Because they're being smashed, the cells also become very permeable. They're not able to hang on to their intracellular components, and so they will leak potassium and they'll leak myoglobin and purines and toxins and all this stuff. They just kind of leak out of the cell. Well, they stay kind of right in this area, right? Because there's not good circulation. There's nowhere to go. And then somebody comes and rescues them and pulls the slab of cement off. We have instant circulation and all that crap that's leaked out of the cells goes everywhere. What happens when you have a ton of potassium that goes everywhere? Yes. Yes, exactly. Exactly. So you can have heart dysrhythmias and they can even go into cardiac arrest. So now you've saved them, they've been conscious, and now all of a sudden they arrest. They also can have myoglobin that gets stuck in the renal tubules, and that causes rhabdomyolysis, or they call it rhabdo, and it can cause kidney failure. And then, I covered them all. So these are like secondary problems after a crush injury. And so sometimes first responders have to be really careful and have fluids and have them on, have ECG stuff right there ready when they go to rescue them and they pull this off there and hurry and get them hooked up because they can end up arresting and having lots of problems before they even get to the hospital. And then hypovolemic shock, if they lacerate an artery, but sometimes a big enough vein, they can lose a lot of blood. They can have a venous thromboembolism and any kinds of infections. Yes, a ruptured aorta. Who said that? Oh, you did too? Like I can't tell between your bank teller things. Who said what?
I call it prison visiting.
Prison visiting, yes. Ruptured aorta. Is it something you saw?
A friend's friend actually died in a car accident. I don't know what happened, but somehow she ruptured her aorta and they didn't get her in fast enough.
Oh, wow. Yeah.
She was like 20.
Wow.
Yeah.
Yeah. Car accidents are rough because you just don't know until you get films what's been done on the inside.
Yep.
So other complications can have tendon lacerations, neurovascular trauma. It can end up with osteomyelitis, but this is a little bit later. This isn't something that's going to happen immediate. And then a fat embolism. So these are particularly from your long bones. You have fat that's also in the bone marrow, and you break that bone, and now you have the risk of losing little fat molecules, little globules, I guess. They can rest in the microvasculature, so in those tiny little capillaries, and you can end up with R&R. Everybody needs some R&R, right? But not this kind. Respiratory neuro rash. So respiratory's first, so you can have acute respiratory distress syndrome. They can end up being very anxious and very restless because of the lack of oxygen. Oxygen needs might be going up and up. They're not perfusing as well. And so about a half of the patients that develop this, that develop the respiratory component from a fat embolism, will need to be ventilated. So it's a big deal to really pay attention and watch because many of them can die because it's missed. Then the neuro component, a level of consciousness change. It can be simple confusion to a seizure. There's no pain, like it's not a headache or a migraine or anything like that, but they will have level of consciousness changes. Yes?
they just wait for the body to reabsorb the fat embolus?
Yes,
too?
yes, the body will reabsorb the fat embolus.
That takes a lot longer. Because blood, you can get anticoagulants to help prevent it from getting bigger and stuff. So with fat,
It's so usually so small that it doesn't take a long time. I don't know an exact timetable on it, but the body will reabsorb it. And then your neural components will just go away. Like very seldom do they have long-term problems neurologically from it. And then your last one is a rash, and it's like a little petechiae, and it can be in their eyes, can be in their upper extremities, skin folds. It can be in their nails. So you'll be able to see the rash piece like that. So just remember long bones, and then it's respiratory, neural, and rash, and that respiratory is a big deal. So if you have a patient who's had femur fracture, and now all of a sudden they're just, you gave pain medicine and they're okay, but they just seem a little like they just can't settle down, and they're kind of restless, and they're kind of, then check their oxygen. If you're giving them some oxygen where you weren't before, then this needs to be on your radar. You need to watch them very, very closely. So there's the fascia, the fasciotomy. I think pictures like that are so amazing. They're awesome. And it makes Logan very, very ill. He walks by and he's like, why do you look at that stuff? All right, ischemic necrosis. This is tissue death from hypoxia. So these are chronic complications. So if you have hypoxia to that injury site and to that bone, then you can have tissue death. And with the bone, they can have ischemic changes too. If you have a fracture that has healed wrong, it has a delayed union. So with the delayed union, it's a fracture healing that takes longer than expected. And sometimes they'll have to, you probably have heard of people that have gone and had it, the cast taken off and it's x-rayed and it's not healed yet. And they have to put it back on and wait a couple more weeks. All right, let's take a break. And come back in 10 minutes, and then we'll finish up with our cast care, our presentation, and our traction. All right, so 10 minutes, and then I just have a couple slides, and I have yours brought up on here already, so we can pull it up. Hopefully, it'll be just that slick.
You never know. Me too.
What's that?
I was like, I have to pee. It's just like, everything comes out. Me too.
for you. I freaking hope I find a culturally diverse patient on Thursday.
I know.
And
Yeah.
time.
Well, and if not, Rachel sent me a little assignment that goes with it. Jody said, wait this week and next week. And then if they still don't have one, then they can do the assignment. They're coming down and stretch the last weeks. I don't want you to have anyway, so we'll wait this week. And if you don't have one, then I'll give you the assignment.
Okay. Yeah, because I have virtual clinicals.
The last one. Mm-hmm.
Oh, that's nice.
I know, a nice end to it, huh?
I did have a little kid that had an Elias takedown that he was like Hispanic,
Mm-hmm.
and his mom spoke a little bit of English, like enough to understand, but he spoke like fantastic English. But they said they're speaking Spanish back and forth, so I don't know if that's like enough. It's just a different like language. That's it though. Like
Yeah, that's culturally diverse.
I don't really remember a whole lot about him other than he had Ilias takedown. He was sick. No,
Ilial takedown?
yeah, Ilias
Uh-huh.
takedown. Sorry, not
Yeah.
Ilias, but I don't remember why he even had Ilias to begin. Yeah, why he had it to begin with. I think it was because like he had some kind of obstruction. They wanted like something to heal,
Uh-huh.
and then they brought it to the surface and then reattached it. But he was on like a PCA pump. He had an epidural that was continuous, but he was still able to get up and walk.
Yeah.
And he finally gets out of bed for the first time. He's like, I have all the energy. I'm so stinking
I
tired.
have all the energy. That's cute.
He was way cute.
How old was he?
He was 8.
Oh my gosh,
Yeah.
that's such a cute age.
Yeah, he was way cute. He was like this tiny little guy too. He really 8.
Yeah, so maybe look at the rubric. And if it's something that you feel like you can speak to with the rubric, then maybe just go ahead and do that and let me know so that I know kind of how much time to plan. We have a guest speaker coming to our post-conference. I think I told you this. Yeah, his name's Ryan, and he was one of our students.
Yeah.
And then went to MP school, and he saw me one day in the hospital and was like, how much do your students know about palliative care? And I said, well, I talk a little bit about it when I do hematology and we do cancer. And he's like, I can give you some information. I said, well, you can come and be a guest speaker. He's kind of a shy guy. And he's like, oh, no, I don't think so. Like, seriously, Ryan, you went to MP school. I'm sure you had to like present some things. And he goes, I did. It was against my will. And and so I said, but this is like your group at the time. I think I had 7 that semester. And so I was like, it's just a really small group. And he goes, okay, yeah, maybe I can do that. But then that landed on Halloween, and he has little kids. He's like, so I'm going to go early, and I'm going to send my, she was the social worker, palliative care social worker. She was amazing. For just like 10 or 12 minutes, she just told us about palliative care and how hospice is kind of an arm of palliative care and resources that they have. Handed out this little paper pamphlet or something, and then answered questions for a couple of minutes. Because I told them about 10 or 15 minutes so that we could do our presentations, which will take a few minutes. And then we have a review game to play that's called Spin the Urinal. And it's one that I put together with Peds review stuff for the semester so that it helps. Shoot. Well, there's prizes involved. You've never come and got your prize from me.
Oh, no, I never did.
I know.
Today. Okay.
I've got stuff. I've got stuff. All right. I think we're good.
Helping to reduce the symptoms, right? So like you're easing the amount of pain, and like you're still trying to help treat them.
For what?
Palliative care, right? You're still trying to help treat
Oh,
them. Like, help treat them.
Sometimes they are still being treated, but they're having a lot of pain. They're having a lot of other needs, and so
Yeah, so you're just like covering to make sure they're comfortable, but not like giving up like hospice. Like we kind of just like keep them from just like die.
Yeah.
More like, okay, we're gonna keep trying to figure out what's going on. We're gonna keep you comfortable. You're not in pain.
Mm-hmm. Yeah. So she talks about it really, really well, and I think he's the one that's going to come on Thursday. So that'll be kind of nice. All right. Take this back off here. All right, so with your cast care, with the initial drying, if you're the one that's holding an arm or a leg or something while they're wrapping that splint or wrapping that cast, make sure that you are holding like this, like very open with your hands. And you're not pressing in at all with your fingers because it'll dry like that. And then they'll have a spot that comes in that's a spot that can rub on an arm or on a leg and cause a sore. Elevate, that does more than you know. Like if you're looking for an IV, dangling an arm off a bed is a really good thing. And so likewise, if you have somebody you need decreased swelling, getting it propped up is a really good thing. Good pain control, and then it prevent pressure sores on the heels and elbows. My son had a friend who, I don't remember what he did to his leg. I think it was a femur fracture actually playing football.
and he was in a wheelchair. He was non-weight bearing for a while, and the crutches were killing his arms. And so he went in a wheelchair and had like the leg that was like straight out. And they kept telling him to change his position or he would do damage to his heel from just having that pressure. And he never did. And he got a decubitus ulcer on his heel in just it wasn't a few weeks. He actually had it for like 8 weeks or so over on his leg. And he ended up having to have skin grafts and everything to fix that. So make sure that they know about pressure sores and about repositioning. No itching under the cast. Don't scratch. Don't do what Chantel's dad did and make a long wire hanger that bends back, and then he wraps it with something to cushion it. So that because I had a cast from here to my ankle, and so then I could just like go down and itch. Don't do that because they can break the skin and it can end up causing an infection. So change the sensation. Put ice on the cast, or you could knock on the cast, so knock on a different area. So if it feels like it's itching here, then knock somewhere else on the cast. And it can change the sensation enough that the brain is focusing on something else. Plus, it's distracting for the kids. So distraction helps. And then antihistamine. So as it gets closer to the end, they have a lot of dead skin under there and it's dry. And so they can get really itchy. So some antihistamines, like some Claritins or Teg, whatever, can kind of help curb that a little bit. Hygiene, so long leg or spica casts, they will do pedaling. And I'll show you some pictures there. But basically they cut strips of moleskin, and then they will stick half of it in the cast and wrap half of it out to keep it clean. And usually with spica casts, it's right around their perianal area. And then we would do these plastic bags. So it would just take a little piece of plastic, like not just saran wrap, but like, what do you call it? A Ziploc bag, but you cut off the top. So you just have the plastic, but usually the freezer bags because they're a little thicker. And then you would stick it with just like skin prep that's kind of sticky and stick it up their back and just press it. That way, if they pooped and it went up the back, this mud flap covered it. And it kept it from going into the cast. And then you were able to reach up under there and clean it a little bit and then pull that mud flap out and be able to tuck another one up there. So I'll show you when I show you a picture here in a minute. If they're bathing, I know you're having a hard time, you're like, I don't see how this is working. When they're bathing, sometimes they get it wet, just tell them to dry it really well. Doctors will tell them, oh, it's waterproof, so you can get it wet. Yes, that's fine. Don't soak it. Don't sit in the tub with it. They can get it wet in the shower. But then it stinks because the inside doesn't dry out real well. So just give them a heads up on that, not to get it real wet because they might be sorry. And then a blow dryer on cool. Do not do it on warm at all. And they can do it right down in the top or right up the bottom of the cast or something to kind of dry right around the edges. But make sure that it's on cool because you can burn them. Okay, so this is pedaling. And so you would take the moleskin and tuck it down inside. And when their little feet get smelly and dirty and you're trying to wash it with a washcloth and a little bit of soap and stuff, you can change this moleskin. And then it doesn't make the whole cast dirty and make it smell. This is the bottom of a spica cast. So you see how they did the pedaling, and that's why it's called that, because they look like little petals. They fold the moleskin in, and then they'll tuck a diaper up under there. So you see how the cast is coming up here, and the little legs are down here. And this, I'm not sure if this tape is holding a mud flap. I don't see the plastic. Oh, it's part of this. It's cushion that has more of the stuffing. But what you would do was take and tuck up underneath here, just a little bit higher than the diaper, put a little bit of skin prep, and stick a plastic to it so it would hang down. And then if they pooped and it went up, because they're pretty notorious for that, then it's underneath the mud flap. And it doesn't go clear up in the back of the cast. Okay. So this is a spica cast from another view, sleepy little guy. And so sometimes if it's hip dysplasia, they'll do both. If it's a femur fracture, sometimes they'll only go half the leg on the opposite side. But it immobilizes the hips, which will help immobilize, which will help healing of the femur too. And then they will do these sometimes for hip dysplasia also. What's that? Right up here?
Yeah.
Yeah, sometimes once this is more up here, like they do it up over the hips. If he had a femur fracture, which I'm guessing this one is because it goes clear to his ankle, and they try to immobilize joints when they have a big fracture like that. But if it's hip dysplasia, sometimes it'll go a little bit higher, right up here, but just below their ribs. So cast syndrome, huge deal. Prevention of constipation is exactly what you need to do 100% of the time. So when they have those spica casts, so you have this, it's pressing on most of your abdomen, right? And so if they get a little bit constipated, you have the abdominal aorta and the mesenteric artery that do this. They make about a 45-degree angle. And the duodenum passes right between there. If there's any swelling in there, like where they have a lot of stool, you can push on the superior mesenteric artery or the aorta, or either or, that makes that angle and cause necrosis in the tissue. About a quarter of kids, 25% of kids who get this cast syndrome will die. It's a huge deal. And so you really need to tell families, like, in no uncertain terms, they cannot get constipated. And if it was an injury and we're giving them opiates, now we have immobility, kids who don't like to eat what they're supposed to, really, don't want to drink a ton except for maybe milk, which dairy products aren't always helping you loosen things up, right? And then now we have opiates. So it's kind of a perfect storm for constipation. So what you need to make sure that they do is that they're eating high fiber foods. And if those kids won't eat stuff well, anything that has oats in it, even if it's a granola bar with chocolate chips, they're not realizing that they're getting some oats in there. Let them have lots of them. And be really creative. Dried fruits, so they can have granola bars and dried fruits. They can have. What's that? Metamucil, yes, Miralax. A lot of times they will send them home with instructions to put them on Miralax. But Colace is also helpful. And that's the one where if they're too small to swallow pills, you can poke a hole in it and drip the Colace out onto just a little bite of something that you're going to give them pretty quickly. A window. So this is starred because it is not a nursing intervention. It is a physician intervention that you will see often that helps combat cast syndrome. And they literally will put a window and they will cut it in the cast right here toward their abdomen to allow for a little bit of swelling, just in case that might happen. But you've got to tell your families about that. Lots of water, lots of fiber. And then turning them and repositioning them at least every 2 hours while they're in the cast. While they're in the cast can be pretty daunting because how long are they in the cast? Weeks, yes, day and night, weeks. So they have got to have a plan. Now, once they start to get a little better and they've been in it for a while, kids get a little more mobile. And they can roll over, and if they're doing that and they see that during the day, and they just watch them a little bit, and I just get up once or twice and see that they're changing their own position, and that will be okay. And then making sure that they do it in the day. But initially, before they get the hang of moving with that, they really need to be turned every 2 hours. All right, traction. So I'm just going to give you goals, and then I'm going to tell you a little bit about Bryant's traction, and then I'm going to turn it over to you. I'm not going to steal your thunder. So they need to reduce the fracture as soon as possible. And that means that they realign it. Okay, so when you reduce the fracture, it's realigned. It doesn't always mean repaired. They have to, they realign it. So like if you have a femur fracture that's displaced, keep forgetting the camera. It's displaced, and then they pull it back and realign it, and then hook them to traction so that it stays right here, so that it's realigned. They still have to go in and have it repaired, so a realignment isn't a repair, but it just gets it to sit right here. It'll decrease spasms. It'll decrease pain. It'll decrease the risk of having neurovascular trauma because now it's slid here. If we're only pushing on vessels, then that's okay. But if we move them at all and it slices through a vessel or does more tissue damage, then that's not good. So that will help decrease tissue injury, vessel injury, but mostly pain and like from spasm muscles and from that bone moving around. And contractures. So with contractures, if it wasn't displaced, if it just broke, and then those muscles are slowly starting to pull it like this, and it will contract. Those muscle contractures will cause a lot of pain and will move that bone. Skin traction. So there's two types of skin traction. Bucks traction is the one that we see the most. And that's just, it looks kind of like that, where it's on the skin. And then it'll go over the bed. Bucks or Brandt's traction is usually done for hip dysplasia for babies. And then there's skeletal traction. So I won't talk about care or anything like that. I will go into Brandt's traction after your presentation. And so let me switch gears here and bring up this presentation. And I posted it on, already on the modules.
Nicole was saying she had 2 full leg casts for 2 years.
What? I had mine for 8 weeks. Well, it might have been closer to 10, but I think 8 or 9 weeks. And I thought I was going to die. That is crazy. What happened to her?
Congenital hip dysplasia.
Ah. Nope. Alrighty. There we go. And this right here goes forward and that goes backwards, and that's a pointer.
Oh, awesome. Cool. And they said they didn't catch it until she was 13 months old.
Yeah.
Oh, wow.
So, I mean, this picture is a bit extreme, full body cast. Most people don't have that, but you can see the little bit of traction going on there. So what is lower extremity traction? Well, I guess I should begin, this is lower extremity traction on an 8-year-old. What kind of nursing diagnosis and interventions would we use, for this patient? So lower extremity traction is just by basic definition is a pulling force exerted on the bones to realign them by some kind of device. And then, like Chantal mentioned, it's most often used on a displaced fracture, usually on the femur because those muscles are really strong, but it can be on a tib fib fracture, but it just pulls it out and separates it on that little. There we go. So that's kind of what it looks like. This is an example of skin traction, where there's just kind of a sling that's wrapped around the leg, and then there's weights that hang off of the bed that will cause that pulling force. But then there's also skeletal traction, where they'll go in and they'll place a pin through one of the bone structures, and it'll stick outside of the skin on either side, and then they'll wrap on the pulleys and the weights off of that. But then once they have the traction in place, they have to stay in the traction for weeks until the bones are sufficiently held together by healing processes. So possible nursing diagnoses, I mean, they're going to have a lot of acute pain just because of the fracture, right? But then they're not going to be able to move really at all, so there's going to be activity intolerance. Most of your nursing diagnoses are going to be related to immobility, being stuck in bed a lot, so their limbs are going to atrophy a little bit because they're not able to use them. Big thing is skin integrity, so you want to make sure you're doing the Q2 adjusting so that they're not having all their weight on the same pressure points. Let's see, risk for injury if they're trying to get up. Neurovascular dysfunction if the traction is placed on wrong, then they'll start getting discrepancies in their CMS. So we got to keep an eye on that. One I didn't put on here is if they are on skeletal traction, then they also have a risk for infection because there is that open skin. Let's see, priority interventions. So while they're on the bed rest and trying to heal, making sure we're checking the skin integrity, tucking pillows like under each side, like doing a Q2, checking the CMS frequently, like you want to do it probably, at least every couple hours, I would say, with the Q2 turning, and teaching the parents on how to do that while they're at home, to watch for any changes and maybe how to correct up the minor things, and then calling the doctor if there's something major going on. You want to make sure things are close to the patient, so like if they're trying to reach for a toy or a book, they're not having to overreach and falling out of bed and hurting themselves. Hygiene is going to be another big one because, again, you're limited with your mobility. And then you want to make sure that you're keeping up on their output and input. So, like, helping with the trying to use the restroom. So, like, urinals, bedpans are going to be your big go-to there. Psychosocial intervention. So, I mean, you get an 8-year-old kid and you tell them they have to lay in bed for 2 months. They're going to be a little antsy. They're going to be bored out of their minds. So trying to find things to help keep them stimulated is going to be important to help them out. So especially like right now with COVID going on and like everyone's trying to social distance and hanging out with friends, is probably a little discouraged. We want to try and find different things to help them stay entertained. I found like one thing that can be pretty helpful is like video games nowadays. You can connect pretty easily online with your friends, so you can still encourage them to interact. Like, for example, with Mario Kart, like set up, playtime with their friends where they both get on at the same time, and then they can still interact. They can have like a going chat. And that would be really good to help them still feel connected and not so socially isolated. You want to make sure that you've got enough like games, puzzles, coloring supplies, whatever the kid's interested in that they can do while they're healing, and then also providing books for them to read. But those are just some ideas for things that we can do to help them out with their psychosocial. So my learning activity is just like 4 NCLEX style questions. So first one, what is lower extremity traction used for? And then you can choose A through D. And then if like online just wants to put it in on the chat. So we got to resolve muscle abnormalities, to realign bone structures for healing, to increase growth rate in children, and as a punishment for misbehavior. Which one do you think? D. Okay. There we go.
Said N.
What's that?
It's a joke.
Oh.
Said N.
Oh. Okay.
Yes, we got B. Next one, which nursing diagnosis would be priority for you to give a child in lower extremity traction? So A, disabled family coping. B, risk for frail elderly syndrome. C, stress urinary incontinence. Or D, risk for injury. B. Okay. Why would frequently assessing CMS in the affected extremity be important? A, to discover changes in perfusion and function. B, to check for diabetic foot ulcers. C, so the patient doesn't get too much rest between assessments. And D, to monitor for spontaneous bleeding.
Yeah, we don't want them to get too much rest between assessments.
No,
we work hard.
We can't have that. And then this is a select all that apply one. Which interventions are likely to be beneficial to a child's psychosocial health due to subtraction? So we got A, to encourage them to interact with friends. B, giving them a variety of books to read. C, directing them to sharpen odd dull pencils. And then D, planning playtime with appropriate games and puzzles.
They all could be right.
They all could be, right? It's like which ones are most likely to be.
I was going to say most likely is going to be. Yeah.
I mean, if you get a kid that like really loves pencils, then your go-to. But I haven't met one like that yet.
Thank you. There's all but 5 of us to clap for you. Clap online. Clap online. That's an awesome option. I love it. Thank you. That was very good. Alrighty. Okay, so we talked about skin traction a lot, a little bit about skeletal traction too. So Bryant's traction is for congenital hip dislocation when it's caught before 13 months or whatever. What'd she say? How long? 13 months?
She was 13 months old before they caught it.
Before they caught it.
And then she had it for 2 years.
Yeah, that's crazy. So here's a picture just like he showed you of skeletal traction. You've got this that goes over the bed, and you've got the pulleys that come down, and then the weights are down here. Usually like a sandbag type weight. So this is Bryant's traction. And so you can see how they can hold their little legs up like this. Their little hips need to be at 90 degrees. And their little butt needs to be off the bed, just that far. So they're just kind of hanging. They've got their body weight that's helping keep traction there. So you can see up here, this little one, it shouldn't look like that. It shouldn't be at an angle like that. And then you can see, oh, she doesn't have toys. Oh, I thought one of them had toys. But you can hang toys from the top up there so that they can see things, see things dangling. And then they also have those little, it looks like a swing set, but it's only about this tall. And you can just set it right over them. And they have little things that they can play with. Yeah, they're pretty cool. Kids love them. All right, so for congenital hip dysplasia, this is modified Bryant's traction. 90-degree angles at the hip and their little butt off the bed. That's a very technical term. Please remember that word. Q4 CMS checks, but 30 minutes after wrapping. So once a day, you want to take those wraps off and check their skin daily. Now, if you're coming on the night shift, I don't know about you guys. There were only certain nurses that I really trusted to do a good job at what they said they did. And some nurses that are like, oh yeah, I took them off. I did a skin assessment. They're fine. I'm not really sure that they did take them off, or I'm not really sure that their assessment was really up to par, because there were just a few that I thought they're just a little bit of a lazy nurse. So even though it had been done probably on the day shift, or they said it had been, when I came on the night shift, I would try and do it before it got late, before they went to bed. So just know it needs to be done daily, okay? And then once you wrap them back up, so they'll do skin prep to help the dressings down, just makes it a little tacky on their skin. And then they wrap it, the little spongy stuff that goes under sports wrap. Oh, I think it's called sports wrap, and it goes under the tape. Yeah. And so they'll wrap kind of with that against the skin prep, and then do the ace wraps. You can see kind of how they have the ace wraps, and they'll go under their foot and make a little bit of a strap and come back up, and then they'll wrap around this way. So you need to be doing CMS checks 30 minutes after wrapping, just to make sure you didn't get them too tight. And the skin prep will help it stay on, and then aim to have the traction on 18 to 20 hours a day. So if a parent wants to hold them, or we want to sit them up a little bit, then we just keep those hips at a 90-degree angle, set them on mom and dad's lap, whatever they need to do. And we don't want to bring that hip out, like move it at all, where it will end up moving in the socket. Does that make sense? So it can kind of move this way, but you don't want it to move this way. All right. Oh, that's where I was afraid with the next slide that I might take away more from your presentation. So this is skeletal traction, like he told you, where you've got the pins to come out from the bone out to the exterior, and then you've got the pulleys tied to the skeletal traction. So this one, I think he's just holding that up there. So just remember, skin traction is like the Bucks traction that has the big foam boot, and skeletal traction has your pins. So nursing interventions for traction: maintain proper body alignment, like you said. when you're repositioning, you gotta be really careful because you don't want to shift and change and move that alignment. And so just slight changes. Like you don't want to roll them on their side. You don't want to do anything like that. And so you can literally stick a flat pillow, which is most hospital pillows, and just tuck it under their hip just a little bit, just to relieve some of the pressure. But before you put them in the bed, knowing that you're not going to be able to move them a lot, before you put them in the bed, then they usually will put like an extra egg crate or an extra, not pillow top, memory foam, something like that, but an extra little mattress on top of the hospital mattress to make it softer for them so you don't run the risk of having any problems. Because you can't really get, like you can do a little bit of shifting with their upper body, but you can't really get shoulders and shoulder blades off the bed. And so just doing slight changes like that are really good. And then the leg that's not affected, so if we're talking lower extremity traction in the leg that's not affected, you can do what you call floating their heels. And you can take a pillow or a blanket and wrap it and put it right underneath the Achilles tendon. And then it floats their heel with no pressure off the bed. And so you can do that when you put the traction on, when you're getting it all hooked up, just roll something under that Achilles tendon to float that heel off the bed. That really helps. Let's see, skeletal traction pin care. Okay, so right here, always check that the weights are not sitting on the floor or the bed. Sometimes families will come by and they'll be talking at the end of the bed and it's like in their way and they're like, oh, and they just pick it up and set it on the bed. Or the patient has kind of slid down in bed and now it's resting on the floor. So to slide them back up, what would you do? You're just going to pull them back up while their legs attached to a sandbag? Yeah. You need to have somebody hold it and gently go with it, but enough that you're not letting off a lot of tension. And then you have a couple other people that have a draw sheet that can go up real slow at a time because they will kind of slide down in bed. And then those weights are sitting on the floor. So make sure that nobody changes the weight, nobody asks to change the weight, that it stays exactly what the physician has ordered. Pin care in the book, in your book on, let's see, on page 845, when it says external fixation devices in the bottom, it says sites are inspected and cleansed every 8 hours. That is not true. And it should be inspected and cleansed every time that your physician has ordered it. So it might be Q8, it might be BID, it might be Q4, but you go by your physician orders. And the very next page, 846, says clean pin sites as prescribed and following standard precautions. Bless you. So just remember the as prescribed part, okay? It's not set at Q8. Just do it as prescribed. And then cleaning the pin sites, this is starred because there's ongoing research all the time in best practice. And I always look it up and up to date before I teach this, just to make sure that it's still on par with what is done most everywhere, what the research is showing. And they've done studies to show hydrogen peroxide half strength because hydrogen peroxide by itself on new tissue is caustic. So you mix it with normal saline. Chlorhexidine, they've done studies on chlorhexidine and they've done studies on just normal saline. Normal saline obviously ranked the lowest. In my book, I would just guess that it prevented infection the fewest amount of times. Chlorhexidine and half-strength hydrogen peroxide are very close. Chlorhexidine was just a little bit higher, but it's also quite a bit more expensive. And so best practice still says half-strength hydrogen peroxide to clean your pins and your pin sites. So move out and away up the pins with a new swab on each pin. So if this is a pin that's coming out on skeletal traction, then I'm going to take right at the base, and I'm going to go around and throw it away. So it's kind of like your trach care. All of a sudden I just had a brain cramp. Where you don't want to just keep scrubbing at the site. Does that make sense? You want to wipe away and get rid of it. Or like even your wound care where you want to wipe away and get rid of it. And so you'll go around and get rid of it. And then you'll go around and come up the pin and get rid of it. And then start where that was and go up the pin and get rid of it. And so you're always going away from that incision. Okay? And then leave it open to air. So when they come back from surgery, they will have some gauze there just to soak up the bleeding. And it'll usually be in between all of the pin sites. You need to get it off there and get it clean, so that it's clean and dry and open to the air, because that dry blood is a medium for bacteria. Bacteria loves it. So you got to get it off there. And then prevent your complications. So your complications, like we had talked before, your neurovascular complications. So looking at those CMS checks, those 5 Ps, making sure that the pain can be controlled, all of those kinds of things. And then I made it very specific because it's kids. I had a case study about an 8-year-old. And then when we got bigger classes, I turned it into a presentation. So that's why it got kind of tailored to a child about that age, so that we get those good interventions in there about the puzzles and the games and the friends and stuff like that. So I think that was pretty great. All right. Show my husband this, and he's like, why is that funny? I think it's really funny. All right. So the clickers, well, the little questions, I think I have the student view here. There's 7 or 8 of them. And so they're in the module, so I will publish them so that you guys can use them. The delegation and prioritization PowerPoint, and I've got that I will publish. And then the assignment. Okay, so let's make this go away. And then I was going to say, then I'm sharing a black screen. All right, let's go to, all right, in your assignments, there's this assignment titled Learning Activity, Pediatric Post-Op Virtual Simulation. I'm sorry I titled it Learning Activity, because it's due today. It is a learning activity. But I gave you, you have 45 minutes. You will knock this out so fast in that time, because we're not done until 11:50. So if you jump on right now and do this learning activity, it'll be done. I was thinking it was an assignment that was longer, but I did it again last night, and it takes 15 minutes maybe. And that's if you're getting answers wrong. Because I will try and do a right one and a wrong one and a wrong one and another right one to see how long it takes. So what you do right here, here are your instructions. You just go to this little website, and then you click on play the game, and it's an interactive. It's just kind of like a VSim, only it's more. They give you options, so they'll start with report. So on here it says practice taking report with your character, and so then your character interacts with other people, so they'll receive report, and then they will go in to take care of this child, and then it'll stop, and it'll give you options, and then you choose one of the options, and it's kind of like those books. Remember that you could choose which direction it would go, and so when you choose that one, then it'll go. And it'll tell you what would have happened if you did that. And if it was wrong, then it'll give you the other 2 or 3 options that you should try again. Okay, and if it was right, then it just keeps going. And then it'll get to another spot, and it'll stop, and it'll give you a couple of options about what should come next. The only answer I will give you is that when they're doing a pain assessment, this is not set in the United States. I'm not really sure where it seems Russian a little bit to me, but their Coldera is called a PQRST. So it took me a couple of tries. I missed it 3 times until I selected PQRST because I had no idea what that was. Okay, yeah. Is it? It's taught in EMS. Perfect. So it's a PQRST. That's what we call Coldera. Yeah, I was interested to see, and
At one point you can see part of her chart, and the P is provokes, because I was trying to figure out what they were, and so you can kind of see on her chart a little bit, but she asks the Caldera questions. Okay, so other than that, I'll let you guys kind of work through that, follow these directions, and then it gives you a little form at the end that tells what you got right and what you got wrong. That's what you submit to this, okay? And then that's it for that. That's kind of my little bit of a learning activity, because we couldn't do my game. I mean, I guess we could with just a couple of you guys, but it's not quite as fun when you have to keep answering all the questions because you don't have a big team. So anyway, so I will publish those other things, and then let me know if you have questions. And that's it for my last one. But I do have a blonde joke that I have to tell you that I don't think I told you. Did I tell you about the blonde in the snowstorm? No. You guys are not shaking your heads. Do you not listen to my jokes? I'm just kidding. So there's this blonde, and she gets caught in a snowstorm. And at first she's really nervous, and then she decides, and then she remembers that her dad said, don't ever be nervous in a snowstorm. Just wait for the snowplow. And when it comes along, just get in behind it and follow it. So pretty soon she sees this snowplow, so she jumps in behind them and is following them. She follows them for like 45 minutes. Finally, the snowplow stops, and the driver gets out and comes around to her and says, can I help you with something? And she said, oh no, I was nervous in the snowstorm until I saw you, and my dad said to always follow the snowplow. And he said, well, I'm done with Walmart's parking lot. Would you like to follow me to Best Buy? Wonderful blonde joke. Cute. Are you upset that I'm telling blonde jokes? All right, let's see. We'll get this. Stop recording.